Good afternoon, ladies and gents. It's my pleasure now to introduce the next session, which is the speed debating, not speed dating. We could do a quick pivot if we wanted to get the energy levels up, but maybe we'll just stick with speed debating. So this year it's entitled The Uncomfortable Truths of Digital Transformation. In time-honoured fashion, I'm going to start with a question. And although this is a digital event, we're now just going to use some very old technology, which is our hands. So, for those of you in the room, who here in the last month has used AI in the pursuit of their workplace? Hands up. All right. Hands up in the last month who here has battled with a piece of technology which should have made their lives easier but was actually making their lives harder? All right. Okay. Question number 2. How many people in this room believe the organisation for which they work is collecting more data than it was 5 years ago? Hands up. And keep your hands up if you think your organisation is performing better as a result of that data collection. Interesting. Okay, great stuff. All right, thank you. To quote William Gibson, the future is already here. It's just unevenly distributed. And I think we've just demonstrated that very, very quickly, haven't we? We have clinicians in one consulting room using AVT to make their lives easier. 3 doors down the corridor, there's a clinician who's rebooting their computer for the 3rd time that morning. Lots of nodding heads I saw there. And while one organisation is talking about data analytics and population risk segmentation, another organisation is working out why on earth nobody is using the dashboard that they spent 2 years devising. And we have staff exhausted by constant change, while we have patients somewhat confused by all of the digital stuff that's happening. So this session is not actually really about technology. It's about honesty. It's about honesty with what's working, with what's not working, honesty between the gap between perception and reality, and we are tackling big questions, and some of these may actually even be quite existential questions, and we're doing it at a time of scarce resource, political upheaval, and organisational uncertainty. So we're talking about digital transformation as one of the defining themes of modern healthcare. It's the centre of national policy, organisational strategy, conference presentations, etc. But behind all of the enthusiasm and the big vision and all of the hoopla, there remain some uncomfortable questions, don't there? There's uncomfortable questions about pace, questions about trust, questions about value, questions about values. And perhaps one of the biggest ones is whether we're genuinely transforming care or simply digitising existing and possibly flawed processes. So the speed debate format allows us to explore multiple themes, and we can do so in a rapid, intelligent, hopefully, competitive, you better believe it, and definitely, hopefully, fun way. And you only have to look at the lineup. We are astonishingly fortunate to have assembled such a line of subject matter experts who not only are people embedded in all things digital transformation, but are jolly good sports and have given up their time so generously. So we have 4 debates, and in the first one we assess data. So it's often said, isn't it, data is the new oil, but I prefer the other one which says data's like garbage. You better know what you're going to do with it before you start collecting it. And so the NHS, being the most centralised health service in the country, has a lot of data, much of it messy, much of it incoherent, much of it contradictory. If it were used well, obviously it would tell us useful things, would give us a narrative but are we creating insight, or are we just accumulating information? The second debate isn't really about technology, it's about people, because ultimately it's people that are going to enact change, and our patients are on the sharp end of those changes. One more app, one more platform, one more dashboard, one more bloomin' login. Or perhaps this is actually the time for a bit of blitz mentality, the can-do attitude, or perhaps the must-do attitude. To quote Gene Kranz, failure is not an option. And then in the third debate, we examine the tension between quality and pace of execution. The impossible triangle, or the iron triangle as it's sometimes called, tells us that you can't have any more than two of quality, pace and cost at any one time. And given that cost is always a constraint, that would seem to indicate that it's impossible to have quality transformation at pace. But do we really want to move that quickly anyway? To paraphrase, transform in haste, repent at leisure. Or is the house burning down so rapidly that we actually can't afford to hesitate and must act swiftly? In which case, are we really sacrificing either quality or being prepared to swallow some eye-wateringly large bills? And then in the fourth and final debate, we consider whether digital transformation is a chimera anyway. Are we witnessing genuine transformation, or are we becoming exceptionally good at talking about it? Are we deluding ourselves by thinking that what are in reality relatively modest incremental changes represent genuine transformation? Or perhaps, as Claire Fuller told us earlier on, we're just a bit forgetful and overlooking that there have been some enormously large infrastructure shifts. So we have two teams. To my immediate right is Team 4, who will be speaking in support of the motions, and just beyond them are Team Against. One speaker will speak for 3 minutes, and the 3 minutes will be delineated by... If you want to. I'll do that. Again, a very analogue piece of equipment, the bell. And then Team Against get their 3 minutes. And because we're running a little bit late, we'll then just go straight to the vote. And the vote will be by Menti, please. So do the vote via Menti. Now, we're going to do a vote before the speakers have even started. So this time we're doing the debate voting slightly differently. You're going to vote before they've spoken, they're then going to speak, and then we're going to take a vote again. So, can they move the crowd? We shall see. Now, a little kind of health warning, which is that the speakers may well be arguing for a position which is not their own or their organisation's. They're doing what I've asked them to do. So be nice to them. If they say something completely crazy or outrageous, it's basically because I've asked them to. Okay, so please be aware of that. So, as they say on telly, let's meet the teams. So, arguing for motion 1 is one of my modality colleagues, Dr. Suthan Ulakanathan. And Suthan is a GP partner down the road in Surrey. He's one of our CSOs and is on the digital transformation team. And, of course, what that means as a CSO is while some of us are running around like Muppets getting really excited about shiny toys, Suthan's sitting there saying, is it safe? Arguing against motion 1 is Asma Nafees, who's the Deputy Chief Operating Officer at Arden and GEM CSU. And I understand is actually only temporarily on loan to healthcare from the legal world, having had a former career as a solicitor. So she's worked across operational transformation, analytics, governance, and large-scale service redesign. and is the person that says, yeah, that's a great idea, but how are we going to make it work? Arguing for motion 2 is Professor Sue Lacey Bryant, who's former Chief Knowledge Officer for the NHS England and now visiting Professor in Knowledge and Information Mobilisation at Manchester Metropolitan University. So she spent much of her career challenging an assumption that often bedevils transformation programmes, which is that more information automatically leads to better decisions. So she's the person saying, so what? And arguing against motion 2 is Dr. Mateen Ellahi. Where have we got to? I'm mixing it up, aren't I? Those of you who are... so we've got the against team and we've got the for team, and I'm going through... Anyway, never mind. Doesn't matter. So Mateen is a GP partner at Stockton-on-Tees, and obviously decided a while ago that being a partner isn't actually busy enough. So in addition to frontline general practice, he indulges in digital health leadership, academic teaching, and international speaking engagements. So I was trying to come up with the... so he's the guy that's saying what, and I think he's actually the guy that's saying, where the hell am I supposed to be this morning? Arguing for motion 3 is Emma Challans Rasool, founder and director of Proud to Be Ops. She has spent years championing operational leaders and helping organisations navigate large-scale change, particularly with a focus on people rather than technology, and is the person who's sitting there saying, but who's going to do this? And arguing against motion 3 is Tara Humphrey, founder of THC Primary Care and the PCN Members Club, through which she supports practices and networks across the country with digital adoption, implementation and service redesign, and is the person who says to PCNs and GPs, let me explain what this means. Arguing for motion 4 is Dr. Vishaal Virani, co-founder of Doctorpreneurs and EMEA Health and AI Partnerships lead at Google. He's head of health for YouTube UK and Ireland, and has spent years helping clinicians engage with emerging technologies while also helping technology companies better understand healthcare. Which sounds fairly straightforward until you remember that one side thinks in algorithms and the other in guidelines. And then finally, arguing against motion 4 is Dr. Gurnak Dosanjh, who's a GP, Deputy CCIO and ICB Clinical Lead at LLR ICB. And the big thing for Gurnak is, of course, those of you who remember, he was recently given a highly commended for Digital Leader of the Year at the HSJ Digital Awards. Yay! Yay! So he spends much of his professional life, obviously picking up awards, damn him, trying to ensure that ambitious digital strategies survive contact with reality. So he's the guy asking who benefits, who gets left behind, and are we improving healthcare or simply digitising existing problems? Please give him a big hand. Right. Okay. So if we can have the voting, please. You've got the... okay, no, now we need to do the voting. Yeah. Yep. We should. Okay. So motion 1 is that this House believes we're collecting more data than we will ever meaningfully use. So let's take a sort of a temperature check, as it were. What have we got? So there are apparently 229 of you online. That's just gone up a little bit, and about just over 100 have voted so far. We didn't think this through, did we? No, when to cut it off? All right, I'm going to stop it there. So we've got 84 for, 54 against. Okay, all right. So motion 1 then. Arguing in favour of motion 1 is Suthan, if you're ready. Let me get my timer all set. Oh, mics. My apologies. Sorry, Suthan. I have done this before, actually. Okay, all right. Your 3 minutes starts now.
It's my daughter's birthday today, and last week we went to Disneyland. She is 7, and she loves princesses. This is not a hobby. This is not a phase. This is a deeply held constitutional position from which no evidence, no argument, and frankly no parent has ever moved her. I've known this since she was approximately 18 months old. Disney are not amateurs. They've spent over a century working out what children want. Armies of behavioural scientists, decades of customer insight, all of it trained on one small girl for a day. And what did all of that tell them? She likes princesses, which I knew, which she knew, which was obvious to everyone within a 5-mile radius. It required no data strategy. It required eyes. And ladies and gentlemen, that is the motion. We are collecting more data than we will ever meaningfully use. We're obsessed. And when we do use it, it tells us what we already know. NHS England has been collecting A&E 4-hour wait data since 2004. The target has not been met since June 2015, not once. The data didn't fix it. It just measured the failure in increasing detail for longer. QoF has generated an extraordinary volume of coded clinical data for over 20 years. Ask any GP whether it has made their patients healthier or their consultations better, then watch their face. Data has become how we avoid making decisions. We dress up procrastination in a dashboard and we call it evidence-based practice. Now, I know what's coming from the other side. The problem, they'll say, isn't too much data, it's too little capability. Invest more and the insights will arrive.
You have a minute to go.
Well, my daughter also believes that if she's patient enough and wishes hard enough, she'll one day see a unicorn. She's 7, and this is very charming. But when a health system does it, when we gesture vaguely at transformative future discoveries, we cannot name, cannot date, cannot describe, we call it vision, which I call the unicorn insights. Just around the corner, just one more data set. The motion says we never will, because the rate of collection will always outpace our capacity to use it. That is not a temporary problem, it's a structural one. I'm still waiting for the unicorn, and so are you. So my daughter didn't need an algorithm to discover she loves princesses. We're not data poor, we are courage poor. At Disneyland, they tell you that dreams come true, but my daughter's best moment of the whole trip wasn't logged, wasn't captured, wasn't in any data sets. It was a look on her face when she met her princesses. Some things you just have to know. Support the motion.
Didn't even have to use the bell. Asma, if you're ready, then your 3 minutes starts now.
So I will bring us back away from the princesses and the fairies to healthcare data. I disagree with the premise, not because organisations don't struggle with data use, but because I've seen firsthand that the problem isn't about excess data. As my learned friend said, it's about the evolution of capability lagging behind. So I'll make 3 points, and I will ground them in my experiences in my analytical leadership roles and also as a non-exec director. So the first one, I've seen what too much data really looks like, and it really isn't the problem. So I spent the first 10 years of my career in the NHS, hands-on with the data as head of business intelligence, working with secondary care data for contractual processes. And the dominant challenge wasn't about the lack of data, it was about fragmented definitions. So we need some form of governance to make sure that all of that secondary care data sits consistently so we can do meaningful things with it. I used to look after the UHCW data, and I know that I had nuances of our data that's disparate from other organisations. So there's something about how do you manage commissioning without having evidence base and the data to do that. And a really good example of the A&E data is we, as commissioners, we undertook an exercise to put some GPs into A&E, and we had the data to understand the peak points and when those GPs would be there and have bang for the buck and sitting in A&E to divert some of the patients away. So I've seen firsthand the benefits of the data that we collect. The second point, I've also seen that shift from counting widgets, which is what we did with A&E data, to analytical capability. So as Chief Analytics Officer within the CSU, we built advanced analytics units with data scientists and saw a very different constraint emerge. So we moved away from that heavy churn reporting, from those dashboards and retrospective widget counting, and towards predictive modelling, data segmentation, population health management. About a minute.
You have a minute to go.
Which led to health inequalities dashboards, benchmarking that allowed clinicians to go and have a look at the hotspot areas in their patch and go and actually tackle patients. And then the final point I'd make is that the idea that we should collect less data is quite a backward step, in that, you know, today's data that isn't being fully utilised because we don't have the capability is tomorrow's training data set, is the information that tomorrow will feature as a longitudinal data record for a patient. When I look back at the beginning of my career 18 years ago, the data that we collected was quite poor, quite patchy. Now it's very rich and we can do meaningful things with it. So I think this isn't about let's collect less data. It's about train our people to understand, create the story, and then have tangible impact. Health inequalities is something we talk about a lot. If we didn't have the data to provide the evidence in order to transact the change, we'd still be talking about health inequalities and not actually doing anything.
Wonderful. Thank you very much. Fantastic. Didn't have to use the bell again. Amazing. Wonderful. Okay, floor. And those joining, we've cleared the decks, as it were. So please now vote and see whether you have been moved by the arguments. I'm trying to give it a little bit longer so that the number who've responded is roughly the same as in the previous vote. But I might have to call it there. Okay, so we've got about 136 responses, so that's 73-63. So, ladies and gentlemen, the winner is Asma, who has got more people voting for her. Congratulations. No, 84, 54, 73, 63. Yeah. We're doing it slightly differently this year. In previous years, when we've done speed debates, we've done it at tables, but the layout here, so we're using technology. So we're also relying a little bit on my mathematical ability, which is not quite what it used to be. All right, but I'm pretty sure I got that right. Okay, motion 2. This House believes that we're entering an era of digital transformation fatigue. So, those of you in the room and those of you joining in the hundreds online, please vote away. Okay, roughly the same number of respondents again. So we apparently believe at this moment that we are not entering an era of digital transformation fatigue. So let's see if the mood of the crowd changes. We have arguing for the motion. Sue, if you're ready, then your 3 minutes starts now.
So there are three key issues: time, fatigue, and digital leadership. 6 years ago, the UK government promised to release thousands of hours of staff time by improving computer access. 6 years on, 35 million staff hours a year are lost between login delays and fractured digital and paper processes. Staff still have to juggle multiple disparate software packages to retrieve basic patient information. And according to NHS England's own Director of Frontline Digitisation, poor usability of computer systems costs as much time as staff sickness. And patients? Digital-first infrastructure relies on an invisible army of informal digital carers, an estimated 25.3 million adults across the UK. And in time, they commit the equivalent of at least 134,000 full-time staff, and that's in England alone. There's fatigue caused by constant system rollouts and platform churn. The UK Society of Occupational Medicine warns against burdening already overworked staff with new technologies without proper support, training and integration. DTS, digital technology stress, from tech rollouts correlates with burnout, with a significant connection with emotional exhaustion. And take the Health Foundation survey on the electronic patient record. 64% say that EPRs have added new tasks to their workload. 62% that they have made some tasks take longer. 53% that it makes their work harder. The NHS Health at Work Network warns we cannot expect digital transformation to solve workforce pressures if it is introduced in ways that add to workload and stress.
You have a minute to go.
Digital transformation needs to engage staff and operational understanding, strong management and experienced leadership. Across 19 of the remaining 25 ICBs in England, not a single Chief Digital Officer role has survived restructuring. What does that say about the organisational will to drive digital transformation? As for agentic AI, there's a gulf between the rhetoric and the reality, and disquiet at the potential impact on jobs, especially where unemployment is already high. Leaders, organisations, staff and the public are all weary of it. Over-promising on digital transformation while under-investing in implementation generates the 3 Ds: dissatisfaction, disengagement and disillusion. I rest my case. We are in and entering a further era of digital transformation exhaustion.
Thanks, Sue. And arguing against the motion, we have Mateen. Mateen, if you're ready, your 3 minutes starts now.
Good afternoon, everyone. Thank you for inviting me, Vincent, and Modality team. It's an absolute pleasure to be here in front of you all. So all the things that you've mentioned, actually, what I would say is actually, I think it's about the execution of digital transformation, not the digital transformation itself. So I think the digital transformation is here to stay. It's the execution that's dependent on all of us. How are we going to execute the transformation itself? So my journey starts from this morning, actually. 7:30, I'm sat on the train. My responsibility as a GP partner every morning to have a look at all the blood results in the morning. And there's 235 sat there. I click a button and go for a coffee. Quickly buy a coffee, come back. Within 2-3 minutes, those blood tests now say 97. 140 blood tests filed in less than 2 to 3 minutes. How can we argue against that? How can we argue against the digital transformation that's happened in the primary care sphere in the last 2 years? Hundreds of hours saved as a practice alone. One practice saving more than 6 figures financially and time, more importantly. And more importantly than that, patient outcomes and staff well-being. So it's not about the transformation, it's about execution of transformation. We do see poorly executed transformation, automation, repeated clicks, and I agree with you that we are logging into 7 different records, 7 different logins to see the first patient in a morning clinic. That's not right. That's about integration. interoperability, not about digital transformation itself. AI is here to stay. My journey goes back to October. A lot of my colleagues here on this stage were there. Global Health Exhibition, Riyadh. Every single presentation had AI in it. If they didn't have AI in it, you wouldn't be presenting on the stage, essentially. AI is here to stay. It's made huge strides over the last 2 years. Let's face it, ambient AI, we've got vendors out there. 80% of administrative workload has been saved by ambient AI. 50% proven documentation time of colleagues has been saved through ambient AI. Workflows, administration, coding is better. The demand management tools are better. We always hear about demand, capacity demand in primary care. We have tools now to prove that we can manage the demand in a better way. We can have workforce transformation through that. It's about, again, execution of digital transformation. Lastly, what I would like to say is digital transformation is here to stay, whether we like it or not. It's going to be the center stage every single year going forward in primary care and secondary care. Healthcare does not stay stagnant. We are constantly evolving. In the UK, our average age is going up, frailty is going up, comorbidities are going up. If we continue to do the same things we have over the last 2 years, the waiting list will keep propping up. It's already 3 million. It's only going to get worse. We need to find something different. We need to include technology. Technology has proved that it can work. Technology is not the issue.
Thank you. Excellent. Okay. If we could clear the Menti, and then we'll take the vote again. Wonderful. Okay. Vote away. Okay, I think we can safely say that Team Against started in a good position and completely tore it up. So well done for Team Against on that one. Okay, so motion 3. This House believes that the real risk is not slow digital transformation, but poorly executed rapid transformation. So those in the room and those online, please vote now. Okay. Again, I'll let that rumble on just for a little bit longer, but I think that's fairly clear that the sentiment amongst all of us is for the motion. Arguing for the motion is Emma. Emma, if you're ready, then your 3 minutes starts now.
Poor execution of rapid transformation is a big problem. We heard earlier, we're all really cool. Yeah? I'm not sure I'm ready to be cool. My son certainly doesn't call me cool right now. We're now speed dating. That's an even more rapid transformation. I'm married, so what's happening there? Didn't even know. That's new to me. I'm not sure I'm ready for that rapid change. But seriously, let's get into the debate here. And let me share with you some key statistics. What's happening across our NHS? Let's look at all of the organisations. Over 95% have deployed the electronic patient record. Only 50% of those organisations are, is it truly working in practice and having a benefit? 80% of organisations have signed up to the Federated Data Platform. Again, less than 40% are actually using it. and it's adding value to their everyday services. E-rostering, another one we're all very familiar with. Nearly 90% of organisations have introduced e-rostering. Less than 30% are actually truly maximising it. So this execution of rapid transformation is a big problem. Only 20% of NHS trusts across the country actually rate themselves as digitally mature. What's going wrong? We've got great technology. We are not introducing it in a way that captures the needs around culture, around engagement, around people understanding the why, the benefits, what's their role in that. It becoming part of everyday practice, not what this department over here does too, or simply it's a piece of kit. We're really great at taking leaps into digital transformation, but we flop at rapid execution of transformation. And what this is resulting is in a real erosion of confidence from our staff and, importantly, the public. There's lack of cultural change awareness. There's a strong resistance to change that is causing, and so much waste. Time, money, people, hope, morale. We are leaking at an exceptional speed. I can go on, but really, people over technology, safety over technology, culture over technology. Slow is smooth, smooth is fast. True digital transformation isn't just about upgrading or deploying first and fast. It's actually about upgrading the way an organisation thinks about change, risk and impact. Top 10 reasons.
You can finish your sentence if you like. Thanks, Emma. Thank you. All right, and now arguing against the motion is Tara. Tara, if you're ready, your 3 minutes starts now.
Okay, I think this motion only stands up if you truly think that rapid means rash and reckless, and it doesn't. I think that, is it a good use of our time? Actually, how many hours have you spent in a meeting, in reoccurring meetings? Let's have a committee. Let's see what Julie thinks. Let's see what Tara thinks. I think that in this room and up and down the country that you guys have amassed at least 10,000 hours of experience when it comes to implementing change. So you know what you're doing, you know what works, you know what doesn't work. And I think that during COVID, and whilst it's an outlier, you guys, or we collectively, changed and transformed quite rapidly. And the guardrails and all the reasons for not doing something was overridden by a real need for our care of our communities and the care of our workforce. And you moved really, really quickly. So I don't think that slow and smooth is, I don't think that's the real risk. I think the risk is if you continue to move along at a snail's pace, people just come in and do it for you, and you're not going to like it. I think all of the sponsors here today have moved tremendously fast. And if any of you have got a phone, version 1 to your iPhone 17, that constant change, that rapid improvement creates momentum. So I really want you to take away from this, rapid does not mean rash. And I think, do it for your friends, your colleagues, your patients. If you just want to move a tiny bit faster, don't be reckless, don't be stupid. There are guardrails, but the system kind of governs itself because there's only so fast you can move in the NHS. So I don't think we have to worry. We're not going to. The risk isn't that we break something for moving too fast, because a lot of things are already broken. I think the real risk is that you carry on doing everything that you're going to do and somebody comes in and does it for you.
Wonderful. Thank you very much. Okay, Menti's being cleared. Please vote away, those in the room and those online.
everyone.
Okay, I'm going to call it there. Now that's interesting. So at the start, 115 for, 22 against. What have we got now? 72 for, 52 against. The methodology that I've been using is to see how the mood of the room and online has changed, and I think that has changed decisively towards team against. Even though the numbers are still showing more people for and more against, but there's a significant shift. So, Tara, well done. Okay, motion 4 now, the final one, and then it is lunchtime, not too late. So, this House believes that digital transformation has become a buzzword rather than a measurable reality. Arguing for is Vishaal. Vishaal, if you're ready, then you're 3. Oh, no, hang on. Almost goofed that up. We got to vote. Please vote away. We'll take the sort of the pulse check before Vishaal and Gurnak start. Interesting, slightly more even. Okay, I'll call it there. So that's 64 to 54. Okay, Vishaal, I kept you in suspense. Let's, if you're ready, then your 3 minutes starts now.
Brilliant, thank you. Well, I'm glad I got a bit of a head start against the digital HSJ Digital Leader of the Year. So hopefully we can keep that momentum going. So digital transformation will have significant positive impact for patients, clinicians, and health systems. There is no doubt about that. But what are the metrics that will prove it, and how do we capture them? That is largely unknown, and the current attempts are predominantly vanity metrics. These vanity metrics create unreasonable excitement and buzz around digital transformation. These vanity metrics focus on utilization, patient satisfaction, clinician experience. Think of the digital triage solutions that some of your practices are using, which makes some patients happy because they make it easier to access the GP. The scribes that you guys may be using that give you joy by reducing documentation burden. But what does that mean in terms of outcomes for the health system, for the patient? Digital products inherently make these interim endpoints much easier to measure. And there is some value in this. At least we can track whether a digital intervention is being used and whether it is creating enough joy to ensure ongoing retention. This does matter, but it is not a hard endpoint that proves success. It proves potential. We need to work harder to develop the frameworks that facilitate measurement of hard endpoints. We also need to provide the incentives so that once these endpoints have been defined and achieved, commercial opportunities open up at scale. Just like the floodgates open when a drug gets through a phase 3 clinical trial, can secure licensing and national funding approval, there's a pathway for scale. To make digital transformation a measurable reality,
a minute to go.
We need to be ready to reward that reality with meaningful commercial incentives. And if you didn't like any of my arguments, at least vote for the bright banana socks.
Thank you. You might need to maybe do a handstand or something so that everybody can actually see the bright banana socks. Or perhaps the photographer can help us out. Anyway, I'm only kidding. Okay, so arguing against is Gurnak. If you're ready, then your 3 minutes starts now.
Thank you. I'd like to start off with a patient that you might all recognise through one way, shape or form. His name is Rocky, a once really agile and resilient young man who unfortunately now you might recognise him. He's succumbed to diabetes, he's got complex COPD, and his memory is lapsing due to a number of knocks through his life. Once upon a time, whilst he was in his prime, if he became unwell, he would have had to go to that big shiny building. He'd be waiting days for his blood test results. His notes were all over the place. And there was no vision from his long-term team in terms of what was going on with him in between care episodes. And now, fast forward into the future, Rocky, if he becomes unwell, he has a virtual ward which can look after him. His clinicians have an electronic patient record which they can see his notes instantaneously. His diabetes is being monitored very, very regularly. Clinicians aren't accessing or looking for notes or something like this, and his healthcare can now be proactive. His teams can be alerted to when Rocky is starting to decline. Now, we can debate what that's called, but I would say that's all measurable. And yes, vanity really does play a role in this. Some of our metrics are vanity-based. When Rocky used to train once upon a time, his body looked great. He was very vain. But sometimes he would lose. Sometimes he would fail. Sometimes he wouldn't quite achieve his goal. And just because the buzzword digital transformation is everywhere and we might overuse it, it doesn't mean that it's not measurable. Rocky having access to his notes, for example, is a win. His friends and family who can now collect his prescription from his local from his local pharmacy is a win. His clinicians who can pay attention to him in a consultation and he now feels heard is a win. These are all measurable outcomes. And I agree with you, we do have a lack of endpoints. I agree with you. But just because we are not at the end goal, we've not won that final fight, it doesn't quite mean that we've not got there. And if we think about Rocky, once upon a time, what this reveals is that it's really, really complex. Digital transformation is really, really tough. We will fail. But what I can say is once upon a time, Rocky had to fly all the way to Russia because he lost his first fight, but he carried on. His training wasn't just a buzzword. His training was a reality which led to success. And it's not just the wins that we're picking up in terms of our measurable realities. We now have in place better governance than we've ever had before. That is measurable. We now know how safely digital deployments are being led. That is the measurable reality. We understand who we're leaving behind better than ever before. That is a measurable reality. We understand how we can improve equity for our patients, for Rocky. That is a measurable reality. So yes, whilst I agree that we might not quite reach the end goal, I truly believe that Rocky and ourselves on the Against team have had a knockout performance today. I hope you understood the analogy there. Thank you very much.
Thank you. Okay, so Menti has been cleaned and cleared. Okay, we'll stop there. Thank you. So there's been a bit of a decisive shift there, hasn't there? So from 64 to 54 in the first bout of voting, we're now at 2790. So, Gurnak, you're on a winning streak at the moment. Well done. Okay. So we are running late, and I'm desperate not to keep you from your lunch. So I will save you from any sort of ponderous summing up. We'll keep the energies nice and high. I will just wrap it up by saying please give these guys an amazing round of applause. They've been sensational.